Good afternoon, everyone. And on behalf of my co-chairman and me, welcome to the BJS Prize Session. We have some excellent talks selected from the abstract competition yesterday. Each of the talks will be 6 minutes. There'll be 3 minutes of questions, and then we'll move on to the next talk. The first person we'd like to invite to the microphone is Ismay Fabre, who is going to talk to us about compression hosiery to avoid post-thrombotic syndrome, the CHAPS randomised controlled trial. Ismay, thank you.
Thanks very much, and thanks, Mr. Chairman, and thanks for the opportunity to talk at the BJS Prize Session. In 2020, we ran a multi-centre randomised controlled trial looking at people who had a first proximal vein DVT, that is popliteal or above. And the research question was, would these patients benefit from wearing a graduated compression stocking on the affected leg regularly or not in terms of post-thrombotic syndrome? I'd like to thank Professor Davies, the trials unit, and all of the collaborators, and Rebecca, the trials manager, for getting this trial off the ground. Apologies if you know all this, but for those of you who don't, DVT is common, and post-thrombotic syndrome affects half of those with proximal deep vein thrombosis. NICE do not recommend wearing stockings, but ESVS do. And there are other societies in other countries which have a range of opinions. And so we felt it was important to look at this problem. Back in the dark ages, I think 2015 or 16, we did a systematic review of the literature. There were 3 existing randomized trials, 2 small ones which showed a benefit for wearing stockings, and a larger one which included a placebo stocking which didn't show a benefit for wearing stockings. Before running the trial, we all tried on the placebo stocking and within about 10 minutes figured out which one was which, just to give you an idea of the blinding in that study. In this trial, we wanted to look at the cumulative incidence of post-thrombotic syndrome at 18 months using the recommended Villalta criteria and this method of adjudicating. And this was done in an assessor-blind fashion, so the patients came without their stocking on and were asked not to reveal what they were wearing at home or not. And this was measured as well. Secondary objectives, as you see below. In arm 1, patients were randomised 1-to-1 to either anticoagulation for a minimum of 3 months in liaison with their local haematologist. In arm 2, anticoagulation plus a graduated compression stocking, providing 23 to 32 millimetres of compression at the ankle. Now, we noted in previous trials there were issues with adherence, and this is really important for a behavioural intervention. So we talked to a behavioural interventionist and added in regular SMS reminders if the patients consented, that was weekly, an educational video which they could watch at the beginning, and indeed they were asked to as part of the consent process, and also a donning aid, of which we had 2 different varieties. They also came back after 2 weeks because their legs may have changed for refitting, and that was done by a nurse who was not involved in the adjudication. Here are the eligibility criteria. So Duster, we're not on Duster, are we? Right, this trial was set up as a 19-centre UK observer blinded RCT, and the sample size calculation looked at a 10% absolute risk reduction in the rates of post-thrombotic syndrome as our prediction from the other trial data with a 90% power. We started this trial in 2020 at the same time as another lovely pathogen called COVID happened, and so our trial was terminated due to slow recruitment. We randomised 152 participants, and 111 made it to at least 6 months. And so the results I'm going to show you are for interest only, and those for trialists who are looking to do further work in this area. And also be interesting to see what has actually happened in the UK to our patients. I'm going to present these as descriptive results. So if we sort of start by looking at people who didn't have a stocking, so control arm, we found post-thrombotic syndrome in 51% of them. So this hasn't changed at all over time. Now, reassuringly, most of that is mild post-thrombotic syndrome, so the bulk of it. If we look at the patients who had a stocking, the rate of post-thrombotic syndrome was 30%. So it was a reasonable signal there that there is something to investigate further. Interestingly, we didn't have any patients with severe post-thrombotic syndrome in the stocking arm, but we have small numbers. We'll have a look at adherence now. So if we look at the red and the grey lines, they are our good adherence patients. We can see that the drop-offs happen over about a year, and we lose about 50% of adherence, somewhere between a third and 50% at a year. And this was through patient self-report. We also measured adherence in a different way by looking at who actually phoned up to reorder stockings, and at 6 months, 2/3 of patients phoned up to reorder stockings. Quality of life scores, I'll show you two things that were interesting from this. So first of all, there wasn't an obvious glaring signal in terms of quality of life differences between the arms. But if you look in the control arm, i.e. people who have no stocking, between time point 0 and 6 months, that's when most of the quality of life effects happen. And so that period seems to be important for patients. And you can see that there wasn't that much of an effect in the intervention arm. And whether that's due to the stocking or not is difficult to know. So what have we learned from this trial? So the results of CHAPS have told us that, number one, it's harder than we think to recruit these patients. The rate of post-thrombotic syndrome in the UK is exactly the same as what it was 20 years ago. And we have a suggestion and a signal probably from this trial that there is reduced post-thrombotic syndrome in the first year of GCS use. Reassuringly, most patients have mild post-thrombotic syndrome, and the quality of life impact on these patients because of that may not be as big as we thought. An alternative hypothesis is that the stocking itself might have an effect on reducing quality of life. It might be uncomfortable. And we can see that adherence drops by just over a third over a year. So the bang for the buck is the first 6 months. If you were looking to do future research in this area, this is what we'd recommend. So good adherence is probably limited to probably just under a year. Below knee stockings, which are what we used in this trial, they appear sufficient to cause a treatment effect. The absolute risk reduction, we wrote at 10%. Probably there's more, possibly. Even 15% would be plausible between these arms. But the overall quality of life on patients using EQ5D, and we also used veins qual, wasn't a huge difference. Thanks very much.
Thank you very much. The microphones are open for questions, if anyone's got any. Did you look at what happened to the proximal DVT? Did you rescan these patients and look and see who was still blocked and who was refluxing?
No, we didn't do imaging follow-up unless there were new symptoms. So we just modelled NHS practice as close as we could.
And how long do you think... Oh, sorry, go on, Ian.
I think it's really difficult to take anything clinically meaningful because you're just vastly underpowered.
Yes.
So it's probably best looking at it as an internal pilot feasibility.
It's exactly what it is, yeah.
And look at things like eligibility rate, recruitment rate, adherence, and you should be thinking about redesigning this so that you do reach your recruitment targets. It would have been nice to see your recruitment curve. You can't do much about COVID, but you could look at other things. What are the other things you could have looked at that you might have actually approached your recruitment targets?
Yeah, thanks for that point. So the recruitment failures, about 40% of the reasons given were COVID restrictions. 40% were patients weren't eligible according to the criteria who were screened. And then there was about 10% patients or coalition didn't feel that they wanted to go into one of the other arms. They didn't feel comfortable being randomised. Those were the main reasons. But I take all of your points. They're entirely right.
Will you run a qualitative pilot study when you do a full study again?
I think it would be extremely useful to see the reasons and explore the adherence more. We had this built in to our study, but we didn't get to the time points that we needed to run that.
All right. Time's up. Thank you very much.
And if we could have our next speaker, who is Hannah Daisley, who will be talking on targeted antibiotic prophylaxis for the prevention of surgical site infection in high-risk vascular surgery.
thank you for the opportunity to present in this session. Why is it important? SSIs complicate up to 40% of lower limb vascular surgeries. The impact of surgical site infections includes increased length of hospital stay, high healthcare costs, and raised morbidity and mortality. SSI rates are likely to vary geographically due to varying resistance patterns regionally. National data shows up to 40% resistance for coamoxiclav and 15% resistance for third-generation cephalosporins. Our local data shows approximately 30% resistance to coamoxiclav, and there's a drive by PHE to reduce antimicrobial resistance through antibiotic stewardship. So what does the current literature show? Single-agent, broad-spectrum beta-lactam antibiotics, such as coamoxiclav or cephalosporins, are recommended for vascular surgery. But it also shows high levels of resistance to coamoxiclav. The implications of using combination penicillin therapy such as these is associated with an increased risk of hospital-acquired infections such as C. diff and HAP. This was a prospective pre- and post-cohort study within a trial. Cohort 1 received generic antibiotics, which was coamoxiclav, and Cohort 2 received the targeted prophylaxis to both surgical site and resistance patterns. So the location of the surgical site and its normal flora and causative organisms likely for infection were considered, as well as the local microbiome of the hospital environment and the patient cohort. The targeted antibiotic guidelines were developed using local resistance data, and this included retrospectively analysing several years' worth of vascular microbiology samples, as well as yearly microbiology reports on the wider regional antibiogram and resistance data. All of this information was used alongside national and international guidelines to develop our specific local data. SSI was diagnosed using either the CDC or asepsis gold standard criteria. The primary outcome was the incidence of surgical site infections up to 30 days post-procedure, and the sample size was calculated using the literature to produce an absolute risk reduction of 20%. This, along with alpha 0.05, 80% power and 20% attrition, highlighted the need for 190 participants. Differences between the cohorts as compared using t-test and chi-squared, and relationships between the variables were evaluated using Pearson's Roe correlation. An odds ratio logistic regression evaluated the effects of variables on infection rates. So we had 191 participants. We lost 20 patients to mortality, withdrawing from the trial, lost to follow-up and cancelled surgery. So we had no statistical differences between the cohorts in most variables, with the exceptions being coronary and MSK disease. Most of the patients were male and the average age was 68. So what did we see? Overall, we had 48 surgical site infections, 30 in Cohort 1 that received the generic coamoxiclav and 18 in Cohort 2 that received the targeted prophylaxis. This showed an absolute risk reduction of 21.2%, relative risk reduction of 53%, and a number needed to treat of just about 5. When we look at the odds ratio, there was only 2 statistically significant variables. Those were BMI and antibiotic type. If we look at antibiotic type alone, the odds ratio was 0.346, showing patients were 3 times less likely to get an SSI with the targeted prophylaxis. If we took into consideration BMI, the odds ratio went up to 0.373, and a raised BMI was associated with an increased risk of surgical site infection. So, Cohort 1, generic prophylaxis was in keeping with the current literature, but presented a much higher incidence of surgical site infection when compared to our targeted prophylaxis group. Our local coamoxiclav resistance was in keeping with the national levels, and this high level of resistance is a likely contribution to the SSI rates with the generic prophylaxis group. Although not analysed in the data yet, it's important to consider that the targeted prophylaxis group may have also not just reduced SSIs, but could potentially reduce other hospital-acquired infections. Targeting prophylaxis to both the site and our local resistance patterns reduced SSI significantly in our trust. Some considerations. We didn't utilise SAS grade for risk stratification of SSIs. We haven't yet looked at whether our antibiotic stewardship has reduced C. diff and hospital-acquired pneumonia. We haven't reviewed our local antibiogram since doing the antibiotic stewardship, so we're not sure how this will shape future guidelines and how often to review these. Guidelines were developed specifically for our centre and are unlikely to be applicable elsewhere, And this has just looked at vascular surgery, so I'm not sure how it fits into the overall surgical picture. To conclude, patients with targeted prophylaxis were 3 times less likely to get a surgical site infection, and the generic antibiotic prophylaxis was in keeping with the national recommendations. Our protocols are unlikely to produce the same impact in other centres, and we recommend looking at the process we used rather than recommending our specific guidelines. Thank you for listening.
Thank you, Hannah. Can I just confirm your level?
I'm one of the new FY2s.
Okay, thank you. Yes,
Hi, I mean, really great, fantastic. You've been very careful not to name the antibiotics, which I applaud you for, but can you tell us how much of a difference it actually made in terms of the agent that people received in terms of prophylaxis? So how many patients actually ended up receiving a different antibiotic as a result of the changes? I
can't remember exactly. I think the differences between the cohort, they were nearly exactly the same sample group size. So in the cohort 1, everybody got comoxiclav. If they underwent a femoral endarterectomy, off the top of my head, I'm not entirely sure, but I think that might be like doxycycline, metronidazole. So there were more narrow spectrum, but more agents to cover the likely causative organisms.
So was cohort 2 just site-specific, or did it also was there a microbiologist for every patient looking at their previous samples?
So it was developed with the ID team and a pharmacist, and it was developed generically, so not patient-specific, but they were developed using retrospective vascular microbiology samples. So they went retrospectively and looked over a period of years to see what was the likely causative organisms and what kind of resistance patterns we were seeing in our vascular patients, and then based the guidelines around what we'd seen locally.
Well, thank you very much.
Thank you.
Professor Davies?
Could you be a bit more specific about the antibiotics that were used in cohort 2? And if you're basing that on results you have, is it truly prophylaxis but rather a treatment option? So I'd be very grateful if you could actually tell us firstly what the antibiotics are.
I would have to go and pull up the actual guidelines because they're quite extensive and change vary depending on surgical site. We use doxycycline quite a lot because we have a lot of sensitivity to that locally. A lot of the lower limb stuff, so anything from the waist down, we would use metronidazole because you have a higher risk of using anaerobes. And whether it's a treatment or not, maybe it's just very good targeted prophylaxis because we don't know whether these patients have an infection to begin with.
So is the answer really the national guidelines are wrong and we should be following the Hull example?
I think the process that we've used in Hull has proved really good results, and I think actually the take-home message would be working closely with the microbiology and infectious diseases team to look at resistance patterns locally and whether a more specific approaches are needed.
Who measured whether a patient had an SSI or not? It's fiendishly difficult if they go home before 30 days to measure it.
So when they were followed up, it was a clinical decision, or if they went and presented to the GP reported into the hospital service, and that was how the SSIs were picked up.
Did you get them to take photographs of their wounds?
I don't think photographs of the wound were taken. It was a clinical judgment, and then we looked whether antibiotics had been prescribed based on their clinical judgment.
Thank you.
Thank you, Hannah.
Thank you.
So let's move to our next presentation. Alison will speak about 3D ultrasound imaging biomarkers.
Hello, everybody. So I'm going to talk about 3D ultrasound imaging biomarkers and using them in order to detect the high-risk plaque at risk of causing stroke. So there's a couple of issues currently with our management of carotid disease. Firstly, in the symptomatic realm, the benefit of CEA in those patients is now being questioned due to the age of the trial data that is based on. In the asymptomatic field, the benefit of carotid endarterectomy over best medical therapy was shown by ACST. However, the absolute numbers having an event each year on best medical therapy was actually very low. Furthermore, stenosis is a surrogate marker of the atherosclerotic disease, which is sitting at the bifurcation, which ultimately stroke is caused by embolism from that disease. So the question we asked was, can additional imaging markers predict which plaques are likely to cause a symptom? We studied 60 symptomatic patients and 50 asymptomatic patients who both had significant carotid disease based on NACIT criteria. We charted their basic demographic data and risk factor data. And then we performed a 3D ultrasound imaging using the pure imaging system on each of these patients. And using that, we calculated carotid plaque volume and also a grayscale median. So the process for assessing with the 3D ultrasound machine, it's a simple sweep up the neck with the ultrasound, which takes about 20 seconds to perform. You then get images, something like what you can see on the top in the three anatomical planes. And from that, you take it onto a software where you can annotate and direct the computer towards the area of interest by marking the artery wall and also the lumen blood border. And with that, we then calculate a volume, the carotid plaque volume, and the grayscale median, which is a measure of the pixel intensity within each pixel of that plaque. Black pixels are denoted as 0, and they show like blood or fresh clots, all the way up to 255, which is a very white pixel similar to bone and indicates calcification. When we compared these two metrics between the symptomatic and the asymptomatic group, first of all, for grayscale median, we saw that there was a statistically significant difference between the two groups. However, and contrary to our other publications on CPV, within this cohort, there was not a difference between the symptomatic and the asymptomatic group in terms of carotid plaque volume. And doing some multivariate logistic regression based on this data, we were able to produce this very nice graph, which shows your probability of being symptomatic on the x-axis versus GSM on the y-axis. And then CPV is a graded bar within the center of that. And if you look right over to the far side of the graph from me, a very low GSM combined with a high plaque volume gives you a very high probability of being symptomatic. So to take this further, we then plotted some ROC curves so we could assess the area under the curve to determine the discriminative ability of each of these markers by themselves and then in combination. And the top three graphs shows each marker individually. The areas under the curve are small for each of those. But I'll draw your attention to the bottom two charts, which show the combined power of adding these metrics together. The CPV and GSM together give us an area under the curve of 0.7, which is moderate discriminative ability. And for that, including the risk factor data, the area under the curve was improved again. So in summary, additional markers of carotid plaque can be assessed by 3D ultrasound. They may help us in determining patients with adverse plaque features who are at higher risk of stroke and therefore help us to manage our carotid patients in the future. The small sample size within this study we feel may have affected the outcome in terms of carotid plaque volume, as this did differ from our previous publications. And clearly, in order to translate this into clinical practice for our patients, a large prospective study of this and indeed other imaging biomarkers which can be gained from 3D ultrasound is needed. Thank you.
Thank you for your nice presentation. Any question from the floor? Professor Davis, yes?
Could you, very nice presentation, but could you tell us the time that they'd have had symptoms? Because plaque morphology changes, and you didn't actually give us any hint as to whether these were all acute plaques or whether they had just had a history of being symptomatic.
No, they're all very acute plaques within this cohort. They were, I think 80% were treated within the 2-week time frame, so they're all acutely symptomatic plaques.
Yes, Matt?
Thanks, Matt Brown, Leicester. So, yeah, very interesting, but the plaques have already ruptured by the time you've imaged them. So, for this to be predictive of rupture, can you give us any idea? I mean, this doesn't look like this predicts rupture at all.
It predicts symptomatic status, is how the statistician termed it. In order for us to predict rupture, we would have to do it prospectively and measure who strokes in the longer term. So it's predictive of symptomatic status at present in order to be truly predictive of a plaque at risk of rupture, and then that goes on to rupture, it'd need to be a prospective study.
And do you think it would be useful to develop machine learning model to predict this kind of outcomes? Because I saw that you used logistic regression, and we know that sometimes machine learning algorithm can do a better job than the classical statistical analysis. I think it will be interesting to do it in your study.
So one thing that I forgot to say within my spiel is that the software that we're using is an AI-assisted software. The user has input into annotating the plaque, but there is an AI assistance to the actual measurement. And with time, we're hoping that that algorithm can be developed further so that there's less user input needed, and therefore that would speed up the acquisition so that it could be done while a patient is in clinic with you.
So this grayscale median, Andrew Nicolaides did a number of studies looking at the predictability of asymptomatic, of grayscale for asymptomatic plaques. And he looked at CT images or MR images of the brain and whether they had embolization, and he looked at TCD in asymptomatics. Presumably you haven't, have you got any of that information?
So the difference in this work compared to Andrew's work is that that was all in 2D, and there is a lot of information out there on grayscale median in 2D ultrasound. There's much less in the 3D setting, and we feel that because we're analysing the whole plaque, it is likely to be more representative. But this is certainly the foundation of all of this ongoing work, and they did show that lower grayscale medians are likely to be found in plaques that have recently ruptured.
And do you think you've taken away some of the variability that existed in grayscale median many years ago? I feel qualified for this. I sit in Andrew Nicolaides' old office.
Yes, so, and there are other metrics, which is why I said other metrics should also be measured, such as the juxtaluminal black area, because that would take in the biggest area of risk that you have at the surface of the plaque, while also the whole 3D GSM just measuring the sort of whole homogeneous amount of the plaque. So I think other markers built into this as well is the most promising for the future.
Happy? Thank you very much.
Thank you.
Thank you.
Thank you. Okay, next I'm delighted to invite Stephen Crockett to the microphone to talk about interim results of the Intercept EVAR trial, a multi-centre pilot randomised controlled trial of carbon dioxide flushing versus saline flushing of thoracic aortic stents. Thank you.
Thank you for that introduction. It's a bit of a mouthful, I know. I'm Stephen Crockett. I'm an Imperial College PhD candidate currently working as an ST4 at Norfolk and Norwich. I'm here to talk about the interim results of the trial Intercept EVAR looking at CO2 flushing versus saline flushing of thoracic aortic stents. So we know that there's a stroke risk associated with a TVAR of around 3 to 8%, and this increases the more proximal the landing zone is. However, we know that also that silent brain infarcts occur in around 80% of patients, and these are MRI-proven acute infarcts after thoracic stenting, but they have no discernible neurological deficit. However, longitudinal data has suggested there's a risk of future stroke, depression, dementia, and mortality. It's been recognised for a number of years that air is retained within thoracic aortic stents from manufacturing room air, and this can't be flushed out with saline alone. This results in air bubbles being released on deployment of the stents, as shown in this benchtop model, which results in air emboli to the brain. CO2 is more dense than air and thus displaces air within a stent. It's cheap and it's easily available and it's dissolvable in blood. So we've shown on benchtop modelling that using CO2 reduces air emboli to the brain, and on the observational data, it significantly reduces the acute MRI head infarcts as well. Based on this, the Intercept TVAR gaseous protection study was designed. It's a one-to-one randomization stratified according to proximal landing zone, with a power calculation based on reduction of a 30% incidence of infarcts for the whole group. The data I'll be presenting today is intention to treat, but we will do per protocol analysis and also subgroup analyses in the future. So the primary objective of this study was to see, is this a feasible study? But the secondary objectives I'll talk to you about today is the diffusion-weighted MRI head infarcts, the transcranial Doppler results, and also the ELISA work that I carried out on S100B, which is a marker of neuroglial injury. So looking at the trial structure, so once they're enrolled, they have full neurocognitive testing carried out, and then they're randomized using a REDCap database into CO2 and saline, or saline alone. In the UK, we then carried out venous blood sampling before, at the end of the operation, and also 24 hours later, and they have transcranial Doppler carried out throughout the procedure, and the stents flushed with either CO2 and saline or saline alone. Within 7 days as an inpatient, they have an MRI head, and they also have inpatient neurocognitive testing to check for delirium or stroke. And then as an outpatient, they have full neurocognitive testing at their first outpatients as well as at 6 months, where we repeat the MRI to check that these infarcts have resolved. So far we've screened 109 patients, 85 are randomized, with 76 having their post-op MRI. Randomization is broadly similar between the two groups, and there was no statistical difference between the demographics of the two arms. So in terms of outcomes, the one I just want to highlight, obviously the stroke rate in both arms is pretty low, 2.4 in CO2 and 2.2 in saline, but it's not statistically significant. Looking at our MRI data, so we've analysed 62 inpatient MRIs, and the mean area of infarcts is shown to have been reduced in all zones in CO2 versus saline, but this has not reached statistical significance. But the reason we wanted to present this data is given the stark contrast in CO2 versus saline for zone 0, where there's a lot of talk of using CO2 to flush these devices. Looking at transcranial Doppler data, so I've got a video here showing some ischemic hits during a deployment of a stent. We analysed 32 cases, with the highest number of emboli being on stent deployment. Gaseous emboli on stent deployment can be reduced with CO2, although it's not statistically significant, and gaseous emboli also overall is reduced with CO2. So looking at S100B, so this is a marker of neuroglial injury, which is quite commonly used in traumatic brain injury studies. So we did it initially before the operation, straight away after the operation, and 24 hours later, which is this ABC here. And what you can see is that clearly all patients are getting an ischemic hit with these cases. And when you looked at the change between A and B, so before the operation to straight away after the operation, what we found is there's a statistically significant difference between the change in S100B in CO2 and versus saline as a marker of that these patients are getting less of a neurological hit when you flush with CO2. In summary, there's 83 cases we've recruited so far with a similar stroke rate, reduced MRI infarcts with reduced number of emboli to the brain from gaseous emboli, and our S100B ELISA work has shown that there's a statistically significant reduction using CO2. I'd like to thank my supervisors, Prof. Richard Gibbs and Ms. Lydia Hanna, for their guidance, and our main funders, HRUK and JP Moulton. But as you can see from this slide, there's a lot of people who have been involved in this study and have been really helpful, so I'd like to thank all of those for their help, and I welcome your questions.
Wow. Who's going to get there first? Rob Sayers.
Thanks, Rob Sayers, Leicester. Two questions. Did you standardise how much saline and CO2 you gave? And secondly, is it likely that the degree of difficulty of the operation, how many passes you made and how many adjustments you made, is a confounding factor in the groups?
So in terms of your first question, so yes, it was standardised. It was 60 mils of saline for all stents with 2 litres per minute for 1 minute of CO2. And we are recording how many stents were included, so we're hoping to do a subgroup analysis for this, because obviously when you're looking at zone 0, there's a lot of stents put in compared to a simple zone 4, which would only have 1 stent. So we are looking at that, yes.
Dave.
Thank you. Dave Bosanquet, South East Wales Vascular Network. You've got a positive finding in terms of a surrogate outcome between the two groups, but in terms of hard clinical outcomes, they're equivalent. So what is the take-home message? Should we or should we not be using CO2?
So I think given the small numbers, it's really difficult to give a should or should we not. I think it would be helpful to have a bigger trial with multi-centre looking primarily at zone 0, zone 1, which are the ones that we suspect is going to be the biggest hit. I think it's a cheap, easy thing to do in an unsheathed device. I think there's very little argument to not do it, aside from the extra 2 minutes it takes to flush.
Okay, Matt and then Mike.
Can you just clarify, has this trial finished?
No, so we're still actively recruiting.
So this is interim results of a randomised control trial?
Yes.
So why have you analysed in the interim?
Because I'm writing up for my PhD thesis, so we're going to write up the results that I have. Obviously, the transcranial Doppler and the S100B markers will be stopped at this stage, but the MRI data will continue.
Have you not now jeopardised the results of the full trial?
We, as a research team, didn't think so. We thought, given the zone 0 results, that we should make people aware. We've been recruiting for 3 years and we haven't really shown any of the results so far, so we thought it was important that we started this conversation earlier rather than waiting for the full results, because it's unlikely that we'll reach statistical significance for zone 0, was the feeling.
Okay, and then come back to the primary outcome. Mm-hmm. Can you just remind us what your primary outcome was? Because I don't think you've told us the results for that.
So it's the feasibility of running a full RCT for looking at cerebral embolic protection, gaseous protection is the primary outcome. So we can't really answer that at this stage.
Okay.
Yes, Mike.
Thanks, Mike Clark, Newcastle. The ICSS sub-study showed that patients undergoing carotid stenting, 50% of them had new white matter lesions on MR distributed across both hemispheres. Mm-hmm. How can you distinguish between the new white matter changes that you're seeing that are due to gaseous emboli and those that are due to atherosclerotic emboli from having a stiff guide wire around the arch?
So that's why the importance that we want to do transcranial Doppler to discern effectively what's the gaseous and solid emboli, because you can actually discern between a gaseous and solid emboli on that. And our previous studies have shown that around 90% of these emboli on TCD are gaseous as opposed to solid. But you're right, in MRI, you can't categorically say whether it's atherosclerotic or gaseous, no.
And presumably if you're using CO2, you'd be hoping that they just get absorbed very rapidly.
Yes, exactly, yeah.
Yes, please, Lars.
So Craig Irvin, Leeds Vascular Institute, Mid-York's Teaching Hospital. I'm not sure that your contention that on TCD-based criteria you can tell the difference between particulate and non-particulate emboli is entirely correct. There's a considerable overlap between the two groups, and I don't think TCD, even with the automated software, is still able to do that reliably. Have you got a comment on that?
So we are looking at the automated software. We also do it manually going through as well, which is not blinded, but we are going to send it off to, there's some AI software in Leicester they're talking about that potentially we may be able to use.
AI to save the day, but in the interim observer error on TCD evaluation is huge.
Yes, I completely agree.
Stephen, thank you very much. Thanks for all your questions.
So if we could have Barnaby Farquharson next, who's going to talk on long-term evaluation of aortic morphological changes in acute type B aortic dissection.
Good afternoon, and thank you for the opportunity to present my work on long-term evaluation of morphological changes in acute type B dissection. Acute type B dissection is an evolving area of research with an increasing trend towards earlier endovascular intervention with the aim of greater aortic remodeling and to prevent late aortic dilatation. This aortic morphology study aims to assess longitudinal aortic remodeling outcomes for patients managed with endovascular intervention versus conventional optimal medical therapy. We looked at a decade of practice at our centre and specifically looked at CT scans on admission at 1 year and at final surveillance scan. The SGVI protocol was applied to each individual scan, and I'll talk about that more on the next slide. So the SGVI protocol was designed by myself as part of my thesis and has recently completed an internal validation study at George's. The protocol was based on systematic review and local expert opinion. The protocol focuses on 5 key areas, including arch morphology, aortic measurements, dissection morphology, endovascular intervention, and aortic remodeling. It was developed using 3 Mensio software, allowing for reconstructed MPR images in parallel and perpendicular views to allow for reproducible analysis. In order to attain accurate remodeling data, aortic measurements were taken at fixed anatomical landmarks from zone 0 to zone 11 on orthogonal view MPR imaging. Dimensions were taken as a straight line perpendicular to the plane of blood flow, such that combined true and false lumen add up to the total aortic diameter. SVS definition for aortic remodeling was used for the purposes of this study, and positive aortic remodeling is defined as reduction in false lumen diameter or increase in true lumen diameter or a total aortic diameter reduction. To give an idea of the scope of practice at George's, if patients present with complicated acute type B dissection, they'll proceed to endovascular intervention if fit for surgery. Patients who present with uncomplicated acute type B dissection, if they present with high-risk features as per international guidelines, they'll undergo a selective endovascular approach, no high-risk features, medical therapy. Looking at the demographics of the patients we looked at, there was no difference in baseline demographics and no difference in time to scan. A total of 144 patients were identified. So looking at the morphological data, so the graph on the left-hand side of the screen is everyone involved in this sort of review. So the red line is the total aortic diameter. You can see that slowly increases over time. The blue line is the true lumen, which increases to 1 year and then stabilizes. And the green line is the false lumen, which reduces to 1 year and stabilizes. And if you look at the average diameter for total aortic diameter, there's no difference, but there is a difference in true lumen and false lumen diameters at the time points we looked at. Looking at growth rates, you see a slightly different story. So you can see in the blue, patients managed medically, and in the yellow, patients managed with TVAR. So you can see clearly here there's an increased growth rate in patients managed with medical management alone. Then looking at true lumen diameter, patients managed with TVAR have a significantly increased growth rate in true lumen diameter post-endovascular intervention. And with false lumen diameter, we see a significantly decreased size of false lumen diameter after endovascular intervention in this group of patients. And if we put that together, we can see that endovascular intervention is statistically significantly increased for endovascular treatment arm. And if we look at how this affects patient outcomes, what we can see is that patients who have positive aortic remodeling are independently predictive of reduced aortic reintervention and reduced dissection-related events. So in conclusion, this study reveals that endovascular intervention induces favorable early and late aortic remodeling, and positive aortic remodelling is associated with improved aortic-related outcomes in this group of patients. Thank you very much.
Thank you, Barnaby. Can I just confirm your level?
ST4.
Thank you. It's open for questions. Rachel?
Can you tell me how you optimised your medical treatment group? So how meticulous were you with their blood pressure? Who looked after it in the sort of post-dissection phase?
So all patients presenting went through the sort of same pathway of goal-directed blood pressure management, managed on an HCU environment with sort of anti-impulse therapy, until whether they're managed with the endovascular or medical therapy, until that could be converted to oral antihypertensives. It is more difficult to ascertain how well that blood pressure is managed once they leave hospital. And I think that's a limitation of this research, is that I wasn't able to access that information. So it's difficult to know whether those patients' blood pressure was as well controlled or optimized post-hospital admission.
So it's essentially left up to the GP?
So patients are discharged with a normotensive state on antihypertensive medications to be continued in the community lifelong. The follow-up data on how well that is maintained, I don't have, unfortunately.
Rao?
Hi, I enjoyed your presentation. What's your understanding of how your results compare with those of INSTEADs that were presented several years ago?
So these results largely mirror the results in INSTEADs. I agree. I think what's interesting about this data is that no one's looked at this in a UK-based population, and also this is a novel sort of imaging protocol to apply. So that's why I thought it would be interesting to see how this group of patients performed in the UK-based sort of real-world study.
So I commend you on your dedicated measurements here. I've got a couple of questions. Your average diameter of the aorta at stenting, if I've got that right, is about 40 millimetres. And presumably that's because you're quite keen on stenting the higher, larger aneurysms in the first place, the uncomplicated type B aortic dissections. So was there any difference in the remodelling in those over 40 and under 40 millimetres? The large aneurysms, did they remodel better than the normal diameter dissections?
I haven't looked at that question, if I'm being honest. But I mean, what you can say from this data, so you're looking at two slightly different groups, because largely the patients being stented have a higher selective of adverse features, including larger diameters. And what we're seeing is that they're attaining good remodelling outcomes, but I don't have a specific answer to those patients who presented with a diameter less than 40 millimetres.
And what happened below the stent? Did you measure the infrarenal aorta?
Yeah, no, I did. So the data that I'm presenting here was the maximum diameter of the 11 zones that I measured. Right. So I did look at what happened to the thoracic aorta that was stented and wasn't stented, and what happens after that. So basically what you see in the thoracic aorta is pretty much exactly mirrors what I've presented today. In the patient, in the sort of visceral segment infrarenal aorta, what you're seeing is increased true lumen diameter and decreased false lumen diameter in the stented population, but you're not seeing the same effects in terms of the total aortic diameter reduction that you do get in the thoracic segment.
Alan, time for one last question.
My question is, and it's maybe a slightly unfair question, do you think these results will influence your centre into those patients who are recruited into the EARNEST trial?
So in what sense, in terms of?
if you've shown such good remodeling, do you now have the same equipoise to put these patients into a randomized controlled trial?
So I think so the randomized, Ernest is looking at just the uncomplicated group of patients. What I've shown today is slightly heterogeneous from that perspective. So the patients being stented are both overtly complicated, so presenting with rupture and malperfusion, and the ones with high-risk features. So I still think the question is valid. I think it will be determined on what the sort of criteria is, and what aortic diameter you're going to decide that is you should stent and should not stent, for example. But I think I don't think it will affect our recruitment personally.
Thank you, Barnaby.
Good answer.
So let's move to our next speaker, Abhilash Surdasanam. Sorry for the pronunciation with my horrible French accent. Sorry. Go ahead.
Thank you very much. Good afternoon, and thank you for this opportunity to present our work, which looks at the use of an automated sarcopenia measurement tool to predict outcomes in patients undergoing AAA repair. So we know that increased frailty equals poorer outcomes in a variety of surgical specialties, including vascular surgery. And as a result, frailty assessments have been advocated as part of pre-operative workup for any patient undergoing surgical intervention, including vascular surgery. Now, the problem lies as to how do you assess for frailty, and one of the metrics is sarcopenia, and sarcopenia can again be measured in multiple ways. Two possibilities include the use of skeletal muscle index, which is skeletal muscle area normalized for height, or another possibility is skeletal muscle density, which is a measure or marker of skeletal muscle quality. So we've previously undertaken a systematic review and meta-analysis which demonstrated that in vascular surgery patients, low SMI did badly in terms of 30-day mortality, post-operative morbidity, and all-cause mortality. So essentially, if you had a low SMI and you were sarcopenic, your outcomes were poorer. So this gave rise to the idea of the SPA study. Now, calculating skeletal muscle index, muscle density, muscle area is a time-consuming process because what it involves is identifying a CT scan, finding the middle of the L3 lumbar vertebra on an axial slice, and manually measuring out all the skeletal muscle area on that slice. And that, when we did each scan, takes about 15 to 20 minutes, which isn't realistic in day-to-day clinical workflow. And the L3 level has been validated in multiple research studies. So we sought to automate that process, and using a deep learning, fully convolutional neural network, developed this automated segmentation tool, which gives you the same output in a matter of seconds. So it identifies the level, gets the skeletal muscle area and the muscle density, as you can see at the bottom there. So we looked at all AAA repairs as being undertaken at Imperial between 2016 and 2020, identified the immediate preoperative CT scan, pseudonymized it, and put it through the segmentation tool. And then 20% of scans underwent manual segmentation by 2 independent clinicians as part of quality control. The primary outcome measure was the correlation between skeletal muscle index at L3 and 30-day composite outcome of death and defined complications as per the NVR. And the complications are listed there with a different score depending on the degree of the complication. So we started off with 528 patients that period and ultimately ended up with 280 who had a pseudonymized scan that underwent automated segmentation. 50 of these underwent manual segmentation as part of quality control. And the primary reason for exclusions included the use of a TVAR. We excluded all connective tissue disease because we felt that that was a separate disease entity as compared to general atherosclerotic aneurysmal disease. And then there were some other reasons for exclusion as highlighted over there. So this is one of the key results I'd like to highlight. So on inter-rater reliability between the 2 independent clinicians' manual segmentation and the automated output, there was excellent ICC of 0.93, which was statistically significant for skeletal muscle area. We noticed the same when it came to skeletal muscle density in Hounsfield units, again demonstrating excellent inter-rater reliability between the two manual segmentations and the automated segmentation. So we felt that this was a reliable tool that could be used, and we were testing the feasibility of using this automated segmentation tool. We then divided men and women because we know that they have different skeletal muscle bulks, and we know that open and endovascular repairs have different risk profiles, so we separated the two out. And I'd like to highlight that in the lowest skeletal muscle density quartile, your mean accordion score was higher, which essentially indicates if you're sarcopenic, your risk of complications goes up. When we looked at women undergoing open AAA repair, I appreciate this is a small sample size, but there was good negative correlation noted between SMI and the accordion score. So the lower your SMI and your sarcopenic, the higher your accordion score and your complications. We then looked at endovascular repair in men and did not identify any significant differences between low and high SMI or SMD quartiles. And when it came to women, the lowest SMI quartile had a higher mean accordion score, which indicated, again, that if you were sarcopenic, your risks went up. Having said that, it did not achieve statistical significance. And we felt there were two reasons for this in the endovascular group. We felt that complications with endovascular therapy usually happen in the later phase. In the immediate 30-day period, the complications tend to be low. And also, the endovascular repair groups are relatively heterogeneous, as we included both complex and standard infrarenal EVARs in this group. So to conclude, that this feasibility study demonstrated that the use of the automated sarcopenia segmentation tool is reliable, rapid, and gives you an answer in a matter of seconds. Patients undergoing open AAA repair with a low SMI or SMD, so essentially those who were sarcopenic, did poorly, and it may be worthwhile considering prehabilitation for these patients or endovascular intervention if feasible. The incorporation of a sarcopenia score on the basis of this CT scan may help improve risk stratification and guide clinicians as to what the optimal strategies might be. But we need to further validate this by a prospective multi-centre trial, and would appreciate your help in the future. Thank you very much.
Yes, please.
Hi, I enjoyed that. Nice pictures, and congratulations to you and your group for finding an AI, another role here. What extra value are we getting compared to some other method that does not require much intelligence, like hand grip strength or a clinical frailty score?
So I think the problem with clinical frailty scores, it takes time. And I think in an outpatient setting, working that out in a pre-assessment setting, it's more a capacity issue is what we felt, whereas this, with every CT scan that's undertaken, if you can give a score straight away without anyone having to do any extra work, especially in today's sort of NHS model, that might be the benefits with this. So that was the idea. Grip strength, we also felt, again, there's a lot of heterogeneity. It depends. A lot of these patients do have arthritis in their hands. So how do you work it out? And this, we felt, would be a uniform measure which could be standardized across. The problem is we don't have cutoff values. The next step would be to identify what a cutoff value for an SMA and SMD would be.
Am I allowed?
Yes.
Yeah, sorry, just one more follow-up question. The L3 level was validated when people were hand-drawing the outline of the skeletal muscle. When you've got an automated tool, you perhaps probably lost an opportunity to measure the level of the skeletal muscle density at multiple levels, which might have given you better value.
So we actually looked at other outputs. We're doing one on the quadriceps and whether this is better or not. But because the L3 has been used so much, we stuck to that in this case.
Hi, Abe. My question's about the workflow through you had a lovely flow diagram. So auto-segmentation is an open source technology now. You can literally download things for it. But it's not as good as normally as you've demonstrated. So can you talk me through the workflow in terms of, presumably it was manually finding the lumbar level, and then you pressed a button? Was it truly then nobody made any adjustments? No one went, actually, it's got the auto-segmentation wrong, it's picked up the wrong muscle? Because if I'm really honest, it's almost unbelievable how accurate that auto-segmentation was.
So thank you for that. So I think a lot of the work, I have to credit Prof. Rockwell for, who was one of my supervisors. So there's a paper in Clinical Radiology in 2022, and what they did was 1,000 scans of patients undergoing oncological intervention were put through this unit architecture automated tool, and that's how it was trained. And those 1,000 scans were manually segmented. So the 1,000 scans were manually segmented and trained using this unit architecture, and you could work it out on the basis of that by comparing what the manual segmentation level was with the automated segmentation. So the training, a lot of the training was already done on a big cohort and validated. So this was more of feasibility in a vascular surgical cohort, but also some cross-validation, which is why we did the 20% manual segmentation. And again, it is sort of patented, which is why it's not out there yet.
But it's truly the machine does the number and there is no visual check from an input from a human being at all, and you got that level of...
Correct, yes. So it's fully, and it gives you a slice, I don't know if you noticed, it gives you a slice confidence, and if it's above 60%, it will accept it. If it's below that, it will reject.
So how many were rejected?
So actually all the ones that we put in came out. So it did not reject any of them. There were some errors, so I haven't shown you. There were a few where there was a bleed out. So the ruptured aneurysms, when you've got a hematoma in the retroperitoneal space, it starts segmenting into the hematoma. So those scans were picked up. So we looked at all the outputs, they were picked up, and we fed that back to the machine to try and train it better.
Hello. Hi. John Gage from Manchester. Nice talk, really interesting, lovely pictures. My question is about the terminology and the title of your talk. So there's a revised European consensus, which I think describes sarcopenia as a progressive generalized loss of muscle mass and function. So you've looked at muscle density in one plane. Can you extrapolate that as a generalized loss of muscle mass, and can you generalize about the functional aspects?
So I think what frailty, there's multiple measures of measuring frailty, and one of the measures is sarcopenia. And sarcopenia, again, can be measured in multiple ways. Because the L3 has been used a lot, we picked that area. And what has been found in the multiple studies is that skeletal muscle density and area at that level, as long as it's normalized for height, can be equated to the rest of the body. We do still have to identify whether there are any better metrics, but that's what was felt.
So, yeah, so it's just the crossover. You're looking at density, but there's a subtle difference between the functional aspects and global muscle mass and how strong that relationship is.
Sure. And we also felt because of density, there's a lot of fatty infiltration in obese patients. The feeling was that density would give you a marker of quality in addition to area giving you quantity.
Last question, please.
Hi, thank you. I was just interested to know how you'd use this predictive tool as part of shared decision-making with the patient.
So I think going forward, if we identify a patient who's sarcopenic and the initial plan was to do an open intervention, we may consider rediscussing with this if there is a straightforward endovascular approach and giving them an opinion or their choice as to how they would like to proceed and what the risks would be. Because if we do show that if you were sarcopenic and your outcomes are poorer, whether they would like to do nothing or have a less invasive approach.
Thank you. Thanks.
Okay, thank you. Ismay Fabre, surgical site infections in major lower limb amputation at an International Multicentre Audit, SIMBA. Thank you very much.
So, hi, I'm Ismay. I'm currently working in South Wales, and thank you for your introduction to talk about SIMBA, which is, as say, a international multi-centre study looking at surgical site infection in major lower limb amputation. We've been supported by Vern and run this study with the help of BICOPS, and we received partial funding from the Accelerator Award given to the Rossini platform trial. But why is this important? So we know that surgical site infection is associated with increased morbidity, mortality, increased antibiotic use and therefore resistance. It can result in sepsis, which may even lead to critical care admissions, poor wound healing and chronic wounds, which puts a huge pressure on our community teams and can even affect the ability to use a prosthetic. Patients may need further surgery, which could be revision to a higher amputation level, and this can reduce ambulation, in turn impacting on mental health, loss of independence, increasing hospital stays, and an overall increase to the health service and poorer outcomes. The James Lind Alliance, in conjunction with the Vascular Society, have identified improving wound healing and improving outcomes as 2 of the top 10 research priorities in amputation surgery. And with SIMBA, we hope to start addressing some of the gaps in knowledge and working towards these goals. So we designed a snapshot, prospective, collaborative study with similar methodology to previous Verne studies such as GIVE and DEFINITE. And we asked any hospital that was providing emergency or elective amputations from any specialty, and the eligibility criteria was any adult having an amputation, excluding those having osseous integration, complex reconstruction, and staged amputations. We collected preoperative demographic and baseline variables, perioperative details and interventions, and postoperative data and outcomes to 30 days. Our data capture period was October 2023 to May 2024, and every centre was required to complete validation to a 95% accuracy. We also looked at adherence to both NICE guidelines and Vascular Society's best practice pathway, and this was done both with the REDCap data, but also a baseline unit survey that was sent out to look at centre-specific pathways and policies around amputation care. If you want to look at our full protocol, it's published online at the JVS GBI. And we had a total of 46 centres enrolled, 12 of which were international, and we had 1,314 amputations recorded. 73% of these were in male patients, and our average age group was 65 to 70. 29.8% were smokers, and 62% were diabetic, with the most common level of amputation being above the knee, followed by long posterior flap below knee. Indication varied, but most commonly it was ischemia, followed by uncontrolled infection. Our headline results were a surgical site infection rate of 10.9%, followed by wound breakdown at 16.7, need for further intervention at 10.8. From our multivariate analysis, we highlighted preoperative variables such as white cell count, MRSA positive, low GFR, a dirty or infected wound, and acute ischemia, as well as perioperative variables such as blood loss, skew flap BKAs, and diathermy for incision as having association with SSI development, and a negative correlation with interventions such as drain placement and perineural catheter. Our outcome analysis showed that SSI was significantly associated with increased morbidity, wound breakdown, need for further intervention, length of stay, and AKI. And interestingly, mortality actually didn't have a significant difference, with a rate of 6.7% in the non-surgical site infection group and 7.4% in the surgical site infection group. Looking specifically at those who did develop surgical site infections, so we had 135 patients. 38 of them developed sepsis, and 18 went to critical care, and 26 resulted in 3 admissions within 30 days. 85 had wound breakdown, and 69 underwent further intervention, 30 of which was revision to a higher amputation level. And although antibiotic prescribing was good, actually only 76 reported micro results, and only 25 of these suggested the organisms were actually susceptible to the prescribed antibiotic therapy. In terms of guideline adherence, this was quite variable with both the NICE and the VSGBI guidelines. We were very good at certain things, such as induction antibiotics, but fell a little bit short in other areas, for example, preoperative bath and shower. We also looked at wound breakdown as an outcome, so we had 16.7%, so 204 patients, and this was due to infection ischemia most commonly, but other factors such as trauma and hematoma were prevalent. And from our multivariate analysis, we highlighted variables such as white cell count and CRP being female, being treated for another infection, for example, urinary tract or respiratory at the time of surgery, a scar or incision from either previous vascular surgery or other specialties, necrosis or open wounds in the ipsilateral limb, poor perfusion, below knee amputations, both skew flap and long posterior, and surgical site infection as associated with wound breakdown. Outcome analysis was not dissimilar to surgical site infections, so wound breakdown was associated with increased morbidity scale, further intervention, and length of stay. So in conclusion, we demonstrated high rates of surgical site infection and wound breakdown, which are both associated with poorer postoperative outcomes. At present, the guideline adherence is quite variable. We've identified pre- and perioperative factors that are associated with SSI and wound breakdown, and highlighted potential areas for targeted risk stratification and intervention. I want to use my last few seconds to say a massive thank you to everybody who's collaborated. We couldn't have done it without you, and Vern for supporting us. And we really look forward to working with you all in the next year with our 1-year outcome data, and also SIMBA T, which is our extension project looking at surgical site infections in transmetatarsal amputation.
Many thanks indeed. Can I just confirm your grade?
A CT2.
That's what it's got here. Excellent. Questions from the floor? Professor Alan Davis.
Could you just tell us what the grade of surgeon who was doing the operation and the length of time of the operations, and how many operations were done in hours and out of hours?
Yes, so I can't remember the exact numbers, but we did look at all of these factors, and none of them came up as significant in our multivariate analysis. So we looked at whether a consultant was present in theatre, as well as who was actually the lead surgeon, so SHO, SPR, or consultant, and we measured operative time in minutes. Off the top of my head, I can't remember the exact numbers, but none of them came up as significant in either the wound breakdown or the surgical site infection analysis.
Keith Jones.
Hi, thank you very much. I just wanted to clarify one of your exclusion criteria. You said that there were staged amputations. So guillotine amputations for sepsis with revision 48 hours later were excluded, is that right?
Yes, yeah.
Can you tell us about the bugs that were grown in the surgical site infections? Would they have all responded? Would they have been targeted by augmentin as a prophylactic antibiotic, or do you need to use the Hull criteria?
So we did collect which antibiotics we used for both induction, prophylaxis, and also for treatment. Being honest with you, we've only actually got our data back in the last couple of weeks, so we're still going through it. And we have a statistical plan with our statisticians from BICOPS to start looking at all the specifics, such as antibiotic use. So watch this space. We may well be coming out with some more info.
Excellent. You must talk as well. Is that Louis?
Yeah, Louis Fliggleston from Swansea. Ismay, thank you very much. It's a very interesting presentation. It sounds like it doesn't matter who does the amputation, what level, etc. And you've got an infection rate around 10% or so. How would you then consent patients and advise them on what measures you're going to take in the future to reduce that infection rate to something that's more acceptable?
So I think the main takeaway from this is actually we're using it to build on trials that will prove causation, but definitely risk stratification and informed consent. Actually, if the trials then prove that these things are associated, should we be risk stratifying and including that in our informed consent process, suggesting potentially they may need to look out closer for surgical site infections? How do we give post-operative information? And actually in our baseline unit survey, we looked at sort of follow-up and support for patients, and it's definitely something we need to improve on in general, but adding sort of this into it would be even more robust.
Will you be considering empowering patients by advising them that they've had swabs taken and that the antibiotics should be reviewed in a certain time, so it empowers them to ask the right question? Because this is all meant to be a team process. Obviously, you've not got data on that, it's just a...
Yeah, absolutely. And actually, some of the Vascular Society best practice pathway recommendations are about support in the post-operative period for these patients. We should be giving them leaflets, they should have access to helplines, and even support groups like the Limbless Association, contact with nurses and follow-up. And that's something we looked at in our baseline unit survey, which actually we're just not delivering to the standard we should be. So definitely, we need to be empowering our patients to be in charge of this.
Thank you very much.
Professor Chester.
The outcomes. Wound breakdown, surgical site infection. You've said that they're often coexistent. Is it possible to, determine between the two, and does it matter to patients? I'm sure it may not matter. But if we're doing trials to try and reduce surgical site infection, we won't have an effect. If the cause of the breakdown is ischemia, we won't have an effect on that. So it may matter. So going forward, what would you choose as your primary outcome? Wound breakdown and surgical site infection together, or just surgical site infection first? And second, have you looked at the reliability of that diagnosis? So if I looked at a wound and said that's broken down because it's infected, would somebody else look at it and say that's broken down because it's ischemic?
Mm-hmm. Difficult question. I think they're both important and they both have different factors associated, but both have consequences for the patient. And I agree, actually, interventions are going, also some of them will probably encompass both. There are going to be things that look at the different ones together. So I think probably we need to focus on one and the other, and then see which ones co-align and how can we actually improve patient care overall for our amputation group as a whole. In terms of going forward with,
Reliability.
That'd be really interesting to look at. I think, the fact we showed from our data that actually only half of them actually had microsamples sent. We should be sending those routinely. Those would help with a fixed diagnosis of whether that breakdown was secondary to ischemia. Be interesting to know, actually.
Ismay, thank you very much indeed.
Thank you.
So next, if we could have Sebastian Vaughan-Burley, who's going to talk on outcomes in octogenarians offered EVAR and electing for conservative management, retrospective cohort study and systematic literature review.
Hi everyone, thanks for the opportunity to present this talk again. So I'm now an ST3 in Oxford, and I was a CT2 when I did this project in Taunton. So the ageing population is leading to increasing numbers of octogenarians reaching treatment threshold for AAA, and in whom EVAR is the primary modality of treatment. However, many octogenarians are managed conservatively due to a variety of coexisting pathologies with very different prognoses. Published literature, which we'll come on to later, considers all turndowns together, making informed shared decision-making with these patients very challenging. Most octogenarians fall into these two categories on the left and right of the screen of either suitable or unsuitable for EVAR after MDT discussion, with a very small number that I haven't included on this chart considered for open repair. However, a small number of those traditionally considered as MDT turndowns will fall into this middle category, where they are fit to undergo the procedure but elect not to for various reasons. And our hypothesis was that these patients may represent a different population to those previously reported on. So how did we define turndowns? We were quite strict with defining which patients were MDT turndowns. And to do this, we evaluated our MDT outcome forms and the clinic letters. We considered the true MDT turndown patients as those who were either outright declined an intervention, or those in whom a trial of raised threshold or conservative management was implemented. And in the context of a shared decision making process in clinic and in alignment with the MDT outcome, we grouped these together as MDT turndowns. We considered patient-selected turndown as those patients suitable in MDT discussion, but a clearly documented patient-centered reason that wasn't previously considered in the MDT as the reason for turndown, and then they went into the patient-selected group. So we retrospectively identified patients from our MDT database from 2011 to 2024, and we excluded patients that were under 80 years considered for open surgery, of which there were a total of 7 or non-elective cases. We performed 2 analyses on this data, so looking at either survival or all-cause mortality, depending which way round you look at it. The first compared all the patients within the 2 populations, and we then performed Cox regression and a 1-to-1 propensity matching process and repeated the survival analysis on those 2 populations. So overall, we had 393 octogenarians that were discussed for elective infrarenal EVAR in the MDT, and of these, 190 were turned down by the MDT, 159 underwent EVAR, and 44 were offered a procedure but declined it. The median survival for the MDT turndown, so not looking at patients who turned down the procedure themselves, was 1.5 years, and we didn't analyse that group further because they've been looked at in previous studies. Comparing patients undergoing EVAR and self-declining intervention, the patients that declined intervention were older, more frequently female, and had smaller aneurysms. This table shows the preclinic characteristics in the 2 groups, and highlighted in green are the ones that we used in our matching model. We also use age in the model as well. For the 159 octogenarians that underwent elective intervention, there were no peri-procedural mortalities. We didn't collect morbidity data because looking at retrospective reporting of minor complications is almost certainly incomplete. This is our first analysis that we performed, which compares all the patients with complete data in both groups. So the median survival for octogenarians declining intervention was 3.3 years, and for those that were offered EVAR and underwent it was 5.3 years. But as we mentioned, this doesn't account for differences such as age and comorbidity in those groups. These are the results after our propensity score matching process. There were 4 patients in the patients selected turn-down group that could not be matched due to various different reasons, but primarily we think it was probably age that meant that they weren't matched to an EVAR patient, so they were excluded. And there was a survival of 3.3 years, a median survival of 3.3 years in that group. The group that underwent EVAR had a median survival of 152 days longer at 3.7 years. For octogenarians who declined intervention with an aneurysm over 6 centimetres, median survival was significantly shorter than those with 5.5 to 6 centimetre aneurysms. So we performed a further analysis excluding these patients, and you can see that for octogenarians with a peri-threshold aneurysm that declined intervention, there was no difference in median survival to matched octogenarians undergoing EVAR. And the big question, what do those patients who don't have intervention die of? Well, as you can see on the bottom, there are 77 patients that we don't have a cause of death for at this point, and we're pursuing that further from GP records. And the main reason for that is working in regional centres. We don't have access to all of these on our primary system. In the patient-selected turn-down group, there were 2 ruptures that we've identified so far, and those were 6.2 and 6.5 centimetre aneurysms. And interestingly, there were 5 deaths that were aneurysm-related in the EVAR group, 4 of which were coded as ruptured AAA as 1A on their death certificate, and 1 was false aneurysm after EVAR as 1C, which was because of multi-organ failure secondary to hemorrhage as their cause of death. I'd just like to briefly mention the result of part of our systematic review, which shows the results from 17 studies that reported outcomes on 3,500 patients on total. So this chart essentially compares the mortality at different time points for the green circles being the patient-selected turn-down patients in our study, and the grey circle and the large grey circle being the median, the weighted mean survival for all of the other studies. And essentially, we feel that this lends further weight to the hypothesis that this group differs from prior reports. So in summary, in our single centre cohort, we think that this represents that EVAR is safe in octogenarians. Sorry, I don't know why that's disappeared. However, in patients who are fit to undergo EVAR, according to the vascular surgery MDT, the outcomes and overall survival do not appear to significantly differ whether they undergo EVAR or opt for conservative management. But this may not be true for patients with larger aneurysms. And overall, we should be cautious in using EVAR in this population. And additionally, if we are considering a raised threshold, should 6 centimetres be the upper limit for this? Thank you very much.
Thank you, Sebastian. Rob?
Yeah, great study. I like propensity scores, particularly. The question is about turn down. It's very difficult to define, and I think you've oversimplified it, really. So in most MDTs, sometimes you reset the thresholds for intervention. So the question is that turned down at that time? In some cases, you turn patients down for elective surgery, but you're prepared to operate for ruptures or for symptomatic aneurysms. And in some cases, you turn them down for one procedure, for example, open repair, but you're still prepared to offer them EVAR. So I think turn down's far more complex. And if you'd have thought about turn down that way, do you think that would affect your results?
So I definitely agree with that. It is complex. So these patients were all turned down for open repair. We didn't consider, none of these patients were considered for open surgery. So firstly, they're only EVAR suitable patients. Secondly, the raised threshold, we considered that to be a turn down at this point. An interesting thing that we are going to look into is whether those patients ever go on to have a procedure or not, or whether they're then turned down again when they reach the higher threshold, or whether they ever reach it because they die of something else before they reach it. I think that'd be interesting to see, because if we show that none of them ever undergo a procedure, then I think we can say these patients have been turned down, and that would simplify that slightly. I agree that it's not quite as simple as maybe the boxes I showed on the screen, but we were very careful to try not to put people who had been considered for EVAR but just held off a little bit into a group where they were turned down definitively.
Matt?
You seem to have quite a high proportion of never smokers in these patients. So do you think this is a different disease from aneurysms we see at 65?
Well, I think that's definitely true. Yeah, these people are probably healthier than our younger patients that have aneurysms. They've lived to be a mean age of 83 and 86 in the two groups. That's already reaching life expectancy for the whole population, not factoring in that these patients have clearly got some degree of systemic vascular disease. So I would say they probably are healthier overall. They probably are a slightly different population. Definitely our 65-year-old heavy smokers are different to these patients, and they've shown that by developing aneurysms earlier in their lives. They may also be more prone to more rapidly growing aneurysms. So, yes, there probably is a difference.
Or do you mean it's different patient, same disease?
Well, they've developed the disease at a different rate, so you could argue it might be a slightly different disease process as well, but certainly different patients.
Rao?
What are your thoughts about the 5 aneurysm-related deaths in the 159 EVAR cohort?
So we know that EVAR is not perfect. There will be some patients who go on to have sac expansion, and if they are unfit for any intervention at the time when that's discovered, some of these patients would have been potentially 90 at this point in time. They may not go on to have an intervention, and then you're not going to treat that sac expansion. We don't have the detailed notes for these patients because in Taunton we have paper records, and in identifying all the causes of death, what we decided to do is collect everything first and then request all those notes and analyse those patients once we have the whole population to look at. So we don't know the exact story there. All we have is scans and whatever was entered electronically, and that's relatively limited in some of these patients.
Hi there, Stephanie Wells, consultant geriatrician working in South East Wales. Thank you for your presentation. Love to hear about research that involves older people, as people who have heard my questions before will know. My point, I guess, is that not all 80-year-olds are the same. And I wondered, were there any frailty assessments done for any of these patients? And in the MDTs that are working now, so for example, recently in South East Wales, we've integrated frailty assessment as part of our MDT discussions. So it's now recorded for every patient over the age of 65 discussed in MDT.
Yeah, so some of this data is going back quite a long way, so 13 years, on a system which is partially electronic. So some of the older records are less detailed and complete in terms of what assessment was done preoperatively or pre-decision. In the more contemporary assessments, yes, definitely. There's an pre-op clinic where there's vascular nurses, anaesthetic assessment, and there is a whole team involvement around that, and obviously it's an MDT, so we want that. In the other patients where we have older records, it's harder to say, probably not in some cases. The other question is, at what point did these patients self-turn down themselves? So some of them will have gone on to have a full workup and assessment and then had to think about it and turned themselves down at that stage. Some of them have not had any assessment and have outright said, I don't want an intervention, even though they've gone through the MDT and been deemed probably suitable, put them through the workup and make sure they are. They've then said, I don't want any investigation, don't treat me. And so there is a difference, you're right, that clearly says that 80-year-olds aren't all the same as well in the way they think. But in more contemporary patients, yes, we've done quite a lot more assessment than historically.
Thank you, Sebastian.
Thank you.
So, thank you to all of our presenters and to the audience for a very interactive session. That's the end of the BJS Prize Session, and thank you very much.